There we go. Thank you for reminding me, Jesse. Well, I know we have a lot to cover, so I'm not going to wait too long, but just 1 or 2 more minutes and we'll get going.
Yeah, and if you can do the slides, I'll just keep talking and it'll be a beautiful thing.
I will do it.
Sweet. Kind of like pay-per-view.
It is kind of. All right. I can get my cat to stop banging on my mouse arm. We're gonna hopefully do this smoothly. My name's Rebecca Buller, and you have joined the Wayside Women's Services ECHO today, and we're so glad you're here. We're excited for information. You know, some folks say data isn't sexy, but I think it's what it helps us do better work, and it's an important part of the recovery and substance use treatment story. Our speaker today is R Moldenhauer. I'm going to let him kind of take the lead, and then at the end we'll have a few announcements. In the meantime, if you haven't already heard me say, please put your name, organization, and email in the chat so we can follow up with you on any other information. We are recording today, just so you know. And Rick has asked, because the data is so rich, we need to kind of move through the experience today. And if you could hold your questions till the end, we'll try to stop at least 5 minutes early or so to entertain some questions. So with that, I am going to share my screen, and Rick is having a bad internet day. So I'm going to run the slides, and he will lead me through that process. And again, I'm so glad you're all here. Share my screen with you. Can we all see it?
If you can put it, if you can put it, can you put it in presenter mode?
I'm trying.
Okay.
Come on. Let me do it.
Force it to comply to your iron will.
Okay, I'm going to stop the share for a quick second. And we're going to I need to enable it. Sorry, guys, had it open, but it wants to reopen.
If necessary, I can break into karaoke, but none of us really want that to happen.
Oh, could you?
That would be a negative thing. It would kind of give away my generation.
Rick, while I'm doing this, why don't you tell people a little bit about yourself?
Okay. Hello, aho, anin, applies appropriate. My name is R Moldenhauer. I'm with the Behavioral Health Division, Minnesota Department of Human Services. I'm with the government. I'm here to help. And today's ECHO session is about a review of data. Specifically, it's around substance use disorder treatment admission trends, almost exclusively Minnesota specific. And so out of the treatment admission trends, what we want to do is extrapolate what we believe to be pervasive use patterns throughout Minnesota. So when I put this together, I wanted to make it as user-friendly and pragmatic for you as possible. So what we're going to do is start out with a couple of overall trends. We're going to look at a couple of specific demographics around primary substance abuse, specifically around methamphetamine and opioids, broken into heroin and other opioids or pharmaceutical opioids, Vicodin, Percodan, Percocet, et cetera. A little bit with demographic, racial differences and disparities. And to try to bring the point home, in the latter part, or the middle part actually of the presentation, what I've done is gone through for a span of about 10 years and taken maps of Minnesota and gone through treatment admissions by the county of residence, where someone was living at the time that they sought professional services by primary substance of choice. So what that will do is give you an idea of where people live at the time they seek professional service for a specific substance. So what it does de facto is give you an idea of where within the state of Minnesota seem to be kind of the pockets, if you would, for primary substances. I can cheat a little bit while we're wrestling with the slide deck and give you a couple of teasers. So all of the treatment admission data that you're going to see here is based on a data collection system we have called DANES, D-A-A-N-E-S, the Drug and Alcohol Abuse Normative Evaluation System. So within Minnesota, oh, some things are starting to happen. Are we good to go?
Does everyone see it?
Yeah.
I see me on the cover of Tiger Beat magazine. What more could you want?
Yep.
Okay, tell me when to click.
Thank you. This is the slide where I usually say throw money, but that's going to be difficult to do here, so I'll just roll with it. If you would like a copy of this presentation, it's free. It's all public knowledge. Just send me an email. If you have any questions about the data collection sources or content, again, just get a hold of me. I am working remotely during the COVID timeframe, so email is the easiest way to get a hold of me, especially if you're looking for data extractions and tables and things like that. Next slide, please. As we go through this, I'm going to throw a lot of information at you in a very short period of time. There's 100 slides in this deck. So I'm going to be speaking fairly quickly through it to try to get through most of this stuff. The one overall arching thing I want you to take away from this is not individual numbers or demographics or drug of primary substance of choice for what county. The biggest thing you can take away from this is to remember that in all of these charts and graphs and trends and patterns, every number in here is somebody. It's somebody's mom, dad, brother, sister, aunt, uncle, auntie, tahanshi, their cousin. Every number in here is a living, breathing human being. Don't forget that. And keep in mind also that these are treatment admission numbers. When we talk about treatment admission, it's a subset of prevalence data. All the numbers in here are people that were in the right place at the right time with the right funding source, where there was a residential slot or an outpatient opportunity for them to seek professional services. So the number of people that could benefit from professional service versus those who actually get into the door. SAMHSA tells us it's about a 1-to-7 ratio. So there's a lot more going on and a lot more people suffering than those that are fortunate enough to be able to access care. Just please keep that in mind. Slide. Behold, the beautiful land of Minnesota, land of sky blue water, star of the north, 32nd state inducted into the Union, home of 87 counties, 11 federally recognized tribes, 86,943 square miles, 10,000 lakes, and not one Super Bowl ring yet. Scattered throughout Minnesota, we have about 450 state licensed substance use disorder programs, about 30 to 40 tribally licensed programs, 16 detoxes, half dozen withdrawal management programs. Anyone who's admitted to any of those programs has information that's put into DANES, the Drug and Alcohol Abuse Normative Evaluation System. So with all but a couple of slides toward the end of this, this is all treatment admission data. We believe that treatment admission data you can extrapolate up to use patterns throughout the state. But again, keep in mind that this is restricted for our discussion here today to treatment admission data. And slide, please. So as a general statement, do you see a black bar going across your screen, or is that just me?
Is it at the top, Rick?
Yeah.
Yeah, I don't know what that comes from the
Okay.
mouse or what it's causing that, because I have it
Okay.
too.
All right. We'll just ignore it for the time being. It's not on the slides, so grab the slide deck when you have a chance. So as we look at general trends throughout Minnesota, the chart you see before you, generally speaking, we are averaging about 70,000 separate treatment admissions per calendar year in Minnesota. So as you look at this chart along the horizontal vertical XY axis, ordinate and abscissa for you statutory types, you're going to see calendar years from 95 to 2019, and then raw treatment admission numbers. So what you take away from this slide is whether we're talking about adolescents or adults, there is a general increase in the number of people that are being admitted to professional services in Minnesota as a function of years. You can see that as good. You can see that as maybe not so good. It depends on your perspective. It's good that more people are seeking services. Maybe it's not so good that more people are having to seek professional services. It's kind of a philosophical discussion. The point is that more and more people are coming into service. General rules of thumb as we go through these slides. More people are seeking services at younger and younger age for the first time they seek treatment admission. Polysubstance use is the rule. It is no longer the exception. The days of yesteryear when Mayberry RFD, when Otis, the town drunk, would come in and whose only substance of choice was alcohol, those days are gone. 2, 3 substances are the norm in today's world. And again, you have younger and younger people seeking treatment services. When we talk to BCA, Bureau of Criminal Apprehension, specifically around methamphetamine and heroin, the purity today is much stronger than it was even 10 years ago. So you have younger people, less experience, more purity of substance at cheaper prices equals higher mortality as well. Next slide, please. So again, same process where we're looking at calendar years and raw treatment admissions. This is for adults. That line you see on the very top, separate of the rest, is alcohol. The primary substance overall in Minnesota that adults seek treatment service, professional services for, continues to be alcohol with a couple of exceptions. But as a general statement, that is still true. So alcohol is still the most prevalent substance, primary substance people seek treatment admission for. What we're going to do is take this slide, pull alcohol off the top, and then expand the lower part of that, all the kind of jumbled lines together, so you can see a little bit better what some of the details of that are. If you would hit the next slide, please. This will be the same information, same data set that simply has alcohol extracted off of it. So again, as you look through the function of calendar years along the bottom there, that kind of lime green spike about 2005, that's methamphetamine. All that we talked about around 2003 to 2005 or 6 was methamphetamine. Even though at its height back then, it only accounted for about 16% of all treatment admissions, it got all the press. So we passed all kinds of laws about it, pseudoephedrine precursor laws, increased legal penalties, so forth and so forth. You see treatment admissions go down for methamphetamine. At the same time that methamphetamine admissions start to go down, you see what on this chart is listed as other opioids start to increase. So as primary substance of methamphetamine went down, we started to see a large increase in other opioids, the pharmaceutical analgesic painkillers, Vicodin, Percodan, Percocet, Oxycontin, Hydromorphone, Dilaudid, Darvocet, and the rest of the narcotic Scooby Snack and Buffet line. That reaches a crest around 2015, 2016. As that starts to tail off, you then see heroin making a dramatic increase. So what the takeaway of this is while alcohol is still the most prevalent for adults throughout Minnesota, the two fastest escalating categories of substance use are methamphetamine and opioids. And then within other opioids, heroin has replaced pharmaceutical opioids. So right now, the big ticket in town, so to speak, is today's version of speedballing. If you're not familiar with the term, back in the days of yore, speedballing was powder cocaine and heroin mixed together. In today's world, it's methamphetamine and heroin mixed together. Please keep in mind, again, that you are talking about a dramatically increased amount of purity just in the last 4 or 5 years. So the methamphetamine floating around today is not the stuff that Larry the Cable Guy is making out in the ice house, pouring A into B and hoping it doesn't blow up on him. It's made, quote unquote, professionally by chemists who know what they're doing. So you have a stronger, more pure product at lower prices that's flooded the market. The same is true with heroin. It's extraordinarily less expensive and extraordinarily more potent than it ever has been before. When you mix those two together in a 24-year-old with lack of life experience, bad things happen. Next slide, please. So just a real quick thing out of the Office of the Demographer for the state of Minnesota. Roughly 85% of the state of Minnesota self-identify as white or Caucasian. You see some of the breakdowns here. The one that I want to point out to you specifically are individuals who self-identify as Native American or American Indian. Based on Dane's treatment admission, people who self-identify as Native have the highest disparity and discongruency by percent of population of any other racial group in Minnesota for any substances, and specifically when we talk about heroin, and methamphetamine. Next slide, please. One of the things that we do in research to try to show the effect on a specific subgroup versus general population is we control for an incidence per 1,000. I don't have time to go into a lot of the math behind it here, but it's just a way that we use to demonstrate how disproportionately affected a subgroup is opposed to the entire population. It's the same process we use for mortality and infectious disease and everything else. So as you look at this slide, controlling for incidence per 1,000 in population across admission for calendar years, that kind of purple line along the top are people who self-identify as American Indian. The teal line across the bottom is non-native or everybody else. And this is purely for treatment admission, regardless of the drug abuse, primary substance. So across Minnesota, for anyone who self-identifies as native, it's 106 per 1,000 for any substance. For the rest of the population put together, it's 9.5. That is a stunning disproportionality for a racial ethnic group that makes up less than 1.5% of the total population of Minnesota. And remember, this is all substances. Next slide. When we start to break this down by certain individual substances, you start to see how some of this changes. So this one is the same process using alcohol. Here's the good news and the bad news. The good news is that in 2009 was the highest spike that we saw for alcohol as a primary substance for natives, and has started to dovetail down ever since. So alcohol for natives is no longer the primary substance that people are seeking treatment admission for. That's the good news. The bad news is what has stepped in to take its place. Next slide. These are the other opiates, or the pharmaceuticals, the pills, if you would. So as alcohol has declined as a primary substance, pharmaceutical opioids stepped in. Again, if you look at the scaling for calendar years along the bottom, you see where methamphetamine started to tail off around that 2007, 2008 frame. Increase of pharmaceutical opioids escalates and skyrockets up to about 2012. We hit 2012. All of the press and the media start talking about the beginning of the opioid epidemic. We have rescheduling of certain medications. Individual practitioners and chains of healthcare start to examine their prescriptive practices around pharmaceutical opioids. So the opportunity to get a lot of pharmaceutical opioids starts to decrease. But you have now an established population of people who are physically dependent on opioids. So what do you think happens? Next slide. Many of them start to step over into other substances or re-engage in previous substance. Same process here, talking about methamphetamine as a primary substance. Like the rest of Minnesota back in 2005, you see the blip or the height of that last wave of methamphetamine. It started to decrease. Then it again skyrockets from about 2012 forward. And the top line are, again, American Indian or Native American. The teal line is everybody else in Minnesota. So when you have a disproportionality of impact of 29.9 per thousand versus 2.5 per thousand, that is a stunningly disproportionate chasm in the effect of a small population within a single state for a single particular substance. Next slide. And heroin. So as you saw the diverted pharmaceuticals start to go down, you have a population who are already physically dependent / addicted to pharmaceutical opioids. The pharmaceutical opioid source or connection goes away because of changes in prescriptive practices. That morally flexible, unlicensed pharmacist outside Chicago Lake Liquors at 3 a.m, he's there to hook you up. And so right now in Minnesota, a balloon of smack is running about $10, depending who your source or hook is. And unlike pharmaceutical opioids, you have no way to predict what is the potency, the purity, or what the cutting agents are in illicit substance. It could be baking soda, it could be fentanyl, it could be Similac. There's no way of knowing. So the heroin itself is stronger. You start to add fentanyl or analogs to it. You also then have a dramatic increase in fatality and mortality that comes as a product of that. The point in this slide, this portion of the slide deck, is simply to illustrate the disproportionality of impact on American Indians versus other racial ethnic demographics. Next one, please. This, I can't see what the top says because of the black bar. I think this is the one that talks about reservation. Oh, there we go. Oh, the bar moved. Freaky weird. Admission to chemical dependency treatment by primary substance. So this is people who are residing on reservation soil in Minnesota at time of admission. Like the slide a ways back, what this does is points out that between 2013 up to the onset of this data, alcohol is now the third substance that people who reside on reservation are seeking treatment admission for. Methamphetamine and heroin are now 1 and 2. Next slide, please. Okay, so the next set of slides here are going to begin to self-animate. And what I want you to kind of watch, they're maps of Minnesota that have the county outlines on them. They're color-coded. And so you're going to see a couple of different slide decks that are going to go through over the next about 3 minutes. Here's the rule of thumb. These are based on where individuals lived for that calendar year, and each separate slide is a separate calendar year in chronologic order. So you're going to see 2010, 2011, 2012, 2013, and so forth. By a primary substance, one's going to be methamphetamine, one's going to be heroin. And then at the end of it is some slides around intravenous drug use to show the incredible increase in IVDU as well. Basic rule of thumb in this is the darker the color that county is coded, the more people that reside in that county sought treatment services for that drug for that year. But as we go through this, I think it'll start to become self-explanatory, and I'll talk a little bit over it as we go. When you have time, if you take the slide deck and look at the legend or the scaling in the lower right-hand corner, one of the things that you're going to notice is the scaling changes in this. In some of the maps, it doubled or tripled from what the incidence per thousand of, say, 2010 or 2011 was up to 2019. Because if we kept the same incidence per thousand, the entire map would have just been jet black and you wouldn't be able to see anything. So again, as we march through this kind of self-animated next portion of this, I'll talk a little bit over it, but keep in mind that you're talking about where people live when they seek treatment services. That gives you an idea of where within that geographic area you see such a great increase in prevalence for use of that particular area. Of point, when you look at these, you're going to see that the greatest volume of substances for heroin, for methamphetamine, are in counties that are either superimposed on or physically contiguous to reservation boundary, especially in the upper parts of Minnesota. So if the animation works the way it should, if you hit the slide, magic should happen. and magic is happening. So if you get a copy of this slide deck, the same animation is built into it as well. So we'll go from 1995 to 2019. And again, it's controlled for incidents per 1,000 of general population. So we're going to start. You saw this when we first started. This is the same slide from the beginning. So this is a visual way for you to see the changes from year to year over a function of time for primary substance. That dotted dashed line is intravenous use, regardless of the substance. It's just the use of needles, whether it's mainlining, skin popping, necking, what have you. As this continues, you see that teal line, which is methamphetamine, hit its spike. And something happened. Okay. So it hits its spike in 05, it goes down. You start to see the pharmaceutical opioids increasing. That will hit its spike around 2012. That will start to level off, and then you see the heroin line go up. And notice the intravenous drug use, methamphetamine and heroin run tangentially with each other, because the use of heroin and methamphetamine mixed together with IVDU as a route of administration is kind of the ticket in town right now. It's the most prominent there is. As we switch to the maps, dead, hoping, there we go. Keep in mind that the darker the color of the county, the more people reside in that county seeking services. The calendar years are along the top. The darker the color, the more people in that county. Thirteen. Notice how the state's getting darker and darker everywhere. That's because there's more of it everywhere. When we talk about methamphetamine as a primary substance, starting in 2007, marching forward, here's a spoiler alert. When you get to 2019, the upper part of Minnesota is just black. And if you were wondering if needles had made its way back into Minnesota, the answer is yes. But when we compare 2007 to 2017, the incidence of needle use has quadrupled as a route of administration. I will defy anyone to argue with me that this does not fit the dictionary definition of epidemic. If this were a contagious illness, if it were anything that was transmittable through breath, through any other form of contact, CDC would be up here putting Minnesota in saran wrap and duct tape. When we talk about substance use, we have to talk a little bit about overdose. Substance use doesn't get that much of a headline anymore, unfortunately, because it's so common that it's not quote unquote newsworthy. If you look at papers up north in particular, like the Pioneer as an example, out of Bemidji, Beltrami area, there was a time 15, 20 years ago, if law enforcement pulled somebody over and they had an 8-ball in the ashtray, that was a big, big deal. Today, if you don't have at least a couple of pounds in the trunk, it's not even worth doing the paperwork for anymore. And I mean that very literally. If you look at the quantities that are seized now by law enforcement, it's pounds and kilos. It's not ounces and grams anymore. This comes from the Minnesota Department of Health off their opioid dashboard. They have since released 2019 numbers after I built this PowerPoint for this. The 2019 numbers compared to 2018 is a 56% increase in opioid-specific mortality just in the last year, just in Minnesota. So when you compare 2018 to 2019 numbers, it literally is a 56% increase. The belief of the increase is from a couple of items. One is the increased purity, the decreased cost, increased prevalence. And now with COVID, social distancing restrictions and so forth, you have more people that are using in isolation with a greater chance of mortality and less opportunity for someone to assist them if there is indeed an overdose that takes place. The 2019 numbers are on the opioid dashboard from the Minnesota Department of Health. If you can't find them, just send me an email. I'll send you a link to it. Next, please. So for non-fatal overdose has also gone up fairly dramatically. The good news is that they're non-fatal overdoses. We, the Behavioral Health Division and other agencies have spent a large amount of time and a large amount of grant money trying to get as much Narcan out of the door as humanly possible to agencies who then distribute it throughout Minnesota. Narcan is an opioid antagonist. It's a reversal agent. It is effective. There are certain groups of people who disagree with its use. I'll try to talk a little bit about that toward the end of this when we get into stigma and some discussions about that. The simple fact of the matter is, if somebody overdoses to the point of mortality, that's the end of the discussion. People who don't have an opportunity to keep breathing don't have an opportunity for anything from recovery to harm reduction or whatever that happens to mean to you. Dead people don't get better. Next slide. Again, the Department of Health has issued out more and more information. When you look at this for 2019, it looks at emergency room visits where opioid overdoses were involved by age bracketing. You'll notice in that sideways bar graph that the largest incidence for ER visits for opioid involved overdoses is 25 to 34 years of age. That is dramatically different than if we would have had this discussion 15 or 20 years ago. Back in that time frame, the 15, 20 years ago, the average client coming into the door for first-time treatment admission, regardless of substance, was going to be in their mid to late 30s. Today, the average first admission is 20 to 24 years of age. So people are coming into the door for services at a younger age because they're introduced to substance use at a younger age, where it's more prevalent, it's cheaper, it's more potent. Physical dependency on a substance can be achieved faster. Consequently, the decay that comes along with chronic substance use comes on quicker at younger ages. Next slide, if you would, please. Okay. If you're familiar with the Minnesota Student Survey, that's where this data pool comes from. Once every couple of years, Minnesota Department of Health, DHS, MDE, Minnesota Department of Education, we go through and we canvass kids in different grades through junior high and high school, and we ask them this big long list of nosy questions about everything from academic achievement to substance use to mental health to this, that, and the other thing, and then out of that we compile some of these numbers. So, excuse me, what this slide does is shows you as a comparison from responses of calendar year 2013 and calendar year 2019 by a percentile, how many are reporting the inappropriate or non-prescription use specifically of pain medication, the opioid analgesics, Vicodin, Percodan, Percocet, and so forth. When we drill down into these numbers deeper, most of the responses that we get to it is that the individual that's using the medication or abusing it, it's not a prescription that is written for them. They are getting it from grandma, they're getting it from auntie, they're obtaining it from some other substance. When we start to ask more questions, especially in youth programs, about the obtaining of the substances, there's a lot of bartering and trading that goes on for opioid analgesics, along with medications used for ADHD, Ritalin, which is methylphenidate, Concerta, Adderall, some of that type of stuff. So there's ways to obtain substances that are technically by prescription without having a prescription for it. And bartering plays a role in that. Next slide, if you would, please. And again, I just want to drive a point home that all the numbers that you see here, these are all people. I I recognize a lot of your names here. I don't know all of you. But if you're in the same world I am, the one thing that brings us all to the table here is everybody knows somebody who's been affected by some part of this in some way, shape, or form. Nobody is immune to this. And again, if you're anything like I am sick and tired of going to funerals. I'm tired of going to senseless, needless funerals that should never have to happen. Next slide, if you would. These are all people. And for any of a variety of reasons, we seem to want to treat substance use separately than we do other conditions, other illnesses, diseases, disorders, however, whatever philosophy or context you happen to have for that. We will demonize individuals with a substance use disorder where we feel sorry for somebody else because they have another or a different medical issue. Well, there's this wide discongruency in how we look at and how we interpret what is substance use, abuse, or disorder versus any other medical condition, any other disorder anywhere. If you're a history buff and you get a chance, go back and Google DSM-1, because most of us probably aren't old enough to actually have a copy of it. DSM-1 was published in 1952. In that publication on page 39, the entirety of what would be today the substance use disorder section is 2 paragraphs on 1 page. And it was listed under the category of antisocial personality disorder. The belief for a long time is that substance use was never a primary thing. It was always a symptom of an underlying mental health disorder. If you look in DSM-5, it's 130 plus pages now and far more eloquent than it has been in the past. My point in this is that while there has been substantial change in how we view the use, abuse, dependency, etc., of substances, we still have a long ways that we can go. If you go to any high school, anywhere, you'll walk in and you'll see the AEDs on the wall, the defibrillators. Where do you see Narcan in high schools? That people overdose on opioids in schools, but you don't see Narcan as part of a standard kit. You see EpiPens for bee stings, but not Narcan. And the answer for a lot of it is the politics around it. Because if we have Narcan, if the school nurse has Narcan, then that might be admitting that we have possibly an issue here. It's fine if we have bee sting kits and we have AEDs, but to have Narcan is somehow viewed as an admittance that it might go on. And we don't want to do that. But then you have factions that want to arm teachers and stuff. Sorry, don't mean to be political. Next slide, please. I am going to ask that we hold questions for a little bit yet. I just throw this slide in there because it's there. I want to talk once more, if you would please. Just a real super quick, we talked about that already, I guess. It's just a slide showing the disproportionality of impact of white and American Indian broken down by age brackets and different things. One more slide, please. I'm already getting tight on time here. This comes from The Lancet. The Lancet is a British publication that's similar to JAMA, Journal of the American Medical Association, and this came out in 2007. This was using what used to be DSM-4 terminology of abuse and dependency, which is a bifurcation that's now gone in the new DSM. And what they tried to do was create kind of an axial equation to talk about what is the physical harm of something versus in that time frame what was seen as use, abuse, and dependency in the old diagnostic categories. And so they went through and they arranged different particular substances that you see on this slide as a function of the physical harm versus dependence. The reason that I have this on here is to try to drive a couple of points home. One, remember, this is 2007. At the very top of this on the 3x3, you see that half bubble that says heroin. That was using heroin samples in 2007. when you had 30% purity. In today's world, the BCA tells us it's more like 80% purity. So if you redid this using the same process in today's samples, that heroin bubble would be somewhere up on about the roof of your house right now. It would be dramatically higher because of the increase in purity. Also, I want to drive a point home. If you were around in the 80s, we society talked a lot about crack babies, and we talked a lot about it, and we had all kinds of press and all kinds of this, and we funded grants and, oh, what do we do, and all this kind of stuff and whatnot. And we've seen a wave of that come through now again, where they're talking about children that were born to mothers who may be using methamphetamine or using heroin or something like that. And collectively, a term that you see in media is addicted babies. And I want to point something out. If you're familiar with DSM and diagnostic criteria, physical dependence and addiction are different. And the reason that it's important to understand that is addiction, by diagnostic definition, requires a degree of volitional choice. That means that when you look at the diagnostic categories, you have to engage in activities and behaviors to obtain, use, recover from, and so forth and so forth. When baby fetus is floating around in that little 9-month in utero jacuzzi, baby does not have volitional choice to what he or she is exposed to. So while a baby may be born physically dependent on an opioid, it is not addicted to an opioid. There's a substantial stigma difference between those two. And we society, basically wrote off and signed off an entire generation of children who were involuntarily exposed in utero to a substance that mom utilized. Let's not do that to another generation for the same purposes. When children are born and the cord is cut, their source, their connection, or whatever you want to call it, stops. So the child will go into withdrawal. Neonatal abstinence withdrawal syndrome. If you're not familiar with it, Google it. There's mountains of literature on it. As neonatal abstinence syndrome can be medically managed. It can be dealt with. The child is physically dependent on an opioid. It is not addicted. The baby is not an addict. Don't hang a label like that on somebody who's a day old. Next slide, please. Let me give you about maybe 3 to 4 minutes of biochemistry and then a little bit of stigma stuff, and then I'm going to shut up for a minute if you all have some questions. So this is a way that I used to try to explain substances, and we'll try to take a real hard, fast run through this. This is a sinusoidal wave. So as you look at this thing, it goes up and goes down. You see the 1, 2, 3 pluses with the arrows and all that. I'm going to try to explain this real quick. So as you go throughout your days, you have ups and you have downs, you have highs and you have lows. This is what makes you human. It's part of our biochemistry. It's a sympathetic, parasympathetic nervous system, blah, 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 blah. So you have ups and you have downs, you have highs and you have lows. The ups are things like Friday afternoon, payday. The lows are things like waking up on Monday morning and April 15th. Over a function of time, those ups and downs and highs and lows give you that kind of hard bar that goes through the middle with the mean sign on the far left. That's average. That's normal, whatever that happens to mean for you. So from a healthcare standpoint, it's 98.6 core body temperature, 120 over 80, 60 to 80 pulse, 12 to 20 respiration, so forth. From a mental health standpoint, it's mood and affect. It's how you look, how you operate, et cetera, et cetera. When you engage in better living through pharmacy, you make highs higher and lows lower. You literally push the normal endogenous biochemical systems in your body to levels that they do not normally naturally go, higher and for longer periods of time. And so since the body is constantly trying to remain in balance or homeostasis, it has to compensate for it. So much in the same way that a predictor of how bad your hangover is going to be is how drunk you got the night before. Anybody who survived finals week probably understands that. The same is true with adaptation. That fancy word across the top, tachyphylaxis, is a nice $5 word for adaptation, or for our discussion here, tolerance. So as you engage in the use of substances, if you increase the volume, increase the potency, switch to something stronger, you're chasing a euphoric effect of it, at least initially. It does something for you that you don't normally experience. Consequently, you have withdrawal from it. In the current DSM, there are 10 categories of substance use. 8 of those 10 have recognized symptoms for both intoxication and withdrawal. 2 of them do not have a recognized withdrawal syndrome. So of those 8, and specifically for our discussion here, things like alcohol, psychostimulants, methamphetamine, cocaine, heroin, other pharmaceuticals, absolutely follow this chain that you see in front of you. So as your body adapts to a certain amount of use of something in quantity and potency, it no longer has the effect it originally did. So you have to then escalate your use. You have to use more in quantity. You have to switch to something that's more potent to get the same effect that you originally got, because you're building tolerance to it. The same reason people transition from 3-2 beer to Jager bombs. And so as you build tolerance to it, you have more on board, the withdrawal is going to get worse and worse. Pharmaceutical opioids, as an example, is a good illustration here. You have, within a spectrum of pharmaceutical opioid, you have really, really mild things that have almost no effect whatsoever to incredibly strong and potent. Lomotil, if you've ever heard of it, is a stool tightener. One of the primary symptoms of chronic opioid use is constipation to the point of impaction. Don't ask me to describe what an impaction is to you over the lunch hour. So Lomotil takes advantage of that particular aspect of opioids, but you cannot choke down enough Lomotil to get a high or a euphoric effect for it. It'd be like eating a 5-pound block of commodity cheese. It's just not going to do it for you. On the other end of that opioid spectrum, you have things like fentanyl and carfentanil, which are extraordinarily strong opioids. So as you develop increased tolerance, you have to switch from the T3s to the Vicodins, to the morphine sulfate tablets, to the fentanyl, to the whatever happens to be stronger to get the same effect. Over a function of time, if you look to the right-hand side of this, you see that little gray triangle tipped on its side where it says TW, LD50, ED50. Those are a couple of terms I'm stealing from pharmacy right now. ED is effective dose, 50. LD is lethal dose, 50. Within pharmacy, you have, if you look at like a PER, a physician's desk reference, or you're a nerd and you're in the research like I am, within every medication in the research that goes behind it, there's ED and LD. ED is effective dose. How much do you have to take of something to have the effect that you're aiming for, versus LD, where you actually overdose something to the point of mortality, which is what ED and LD means. So the therapeutic window, that TW, therapeutic window is that range between when you have enough on board to do what you want it to do, but not so much on board that you have unwanted or iatrogenic side effects. Over a function of developing tolerance, what is normal or mean or average changes. So the line between how much you need to use as an effective dose versus how much becomes a lethal dose gets narrower and narrower and narrower. And that's why you see the point of that triangle gets finer and finer. You get to a point where how much you have to ingest to get out of being in withdrawal approaches a lethal dose toward mortality. What kills most people in active use is not overdose as a function of chasing euphoria. It's overdose as a function of trying to get out of being in withdrawal. If you've ever been or seen somebody in withdrawal, it is unpleasant. This is not something people chase or want. There's no addict booth at career day. Nobody signs up for this. They're just trying to survive. And a common term that you'll hear amongst people that are using is just be well. And all that simply means is don't be sick. Don't be in withdrawal. It's not about being high anymore. It's about not being sick. Next slide. That normal or mean or average line, you'll notice how this kind of takes a downward dip from 0 to 12, and then you see the little squiggly lines that follow that. Over a function of continued use and adaptation or tachyphylaxis, intoxication and withdrawal cycles, the ability to even get intoxicated begins to diminish because you've developed tolerance. That does not take away the ability to be in withdrawal. And so again, you get to a point where you're not using a substance or cross-using substances to not seek an intoxicant effect anymore. You're using it to simply not be in withdrawal. And for some people, that's kind of a pragmatic definition of quote unquote addiction. It is more fundamentally a process of trying to survive and not be sick. You don't demonize anybody anywhere else for any condition for seeking pain relief for anything from anything. But if you're using to try to get out of being in withdrawal, somehow it's magically your fault, and we're going to get busy arresting and incarcerating you for it. Next slide, please. I can't talk about substance use and not throw in a slide about stigma about it, and then I'm going to shut up because if anybody has any questions, I want to have a chance to try to politically dance around vaguely answering your question. When we talk about stigma, in my personal opinion, is weaponized ignorance. If you're old like me and you remember Jefferson Airplane, you remember the line that you see on top here, when the truth is found to be lies. When you start to realize that truth and lie or untruth is a sliding scale, and stigma exists in between the two. So if you think of it like during growing season, stigma is something that you plant in ignorance, you water and fertilize it by denial and projection. It's not us, it's those people. It doesn't happen in our community, it happens over there. It's not here where the wealthy people are, it's over there in that trailer court. It's never us, it's them. As I go around and I present at a lot of conferences, I talk to a lot of people because that's what they pay me to do. One of the things that I get feedback or I hear back a lot of times is people are hesitant, they're afraid, they're concerned about saying anything because of fear of reaction, rejection, whatever potential perceived consequence might happen. And one of the things that I hear often is individuals, especially around addiction or really around pharmaceutical opioid stuff, where it's quote unquote prescribed by a doctor, so it must be okay then, is the idea that you shouldn't, wouldn't, couldn't say something because of the 12-step model and the idea or the concept of anonymity. And I would like to submit for your review evaluation that there's a difference between anonymity and silence. Anonymity says that the message is more important than the messenger. Doesn't matter who says it, it's that it's said. Silence says the message isn't important enough to waste time saying something about. Anonymity can still get the point across. Silence kills people. And it's maybe time we stop letting silence kill people. So you got to kind of make a call for yourself. If you've seen The Matrix, which is like, the middle generation of Keanu Reeves after Bill and Ted and kind of before he went all John Wick on everybody, the whole red pill, blue pill thing, which of the two do you want? And we as society, we as individual people in Minnesota, we as at times a helping profession, we have a wide array of thoughts and opinions and ideas about what's good and what's bad and what's appropriate and what's not. Just as you try to formulate your own philosophies about stuff, don't ever forget that this was about, and at least in my opinion, should be about helping and meeting clients where they're at. If that's abstinence, if it's reduction of use, if it's whatever it happens to be, it's for the benefit of the client. It's not about revenue. The one thing you can never control for in any piece of research is who funded it. People fund research to sell a product. It could be a product, it could be a philosophy, it could be an idea, it could be a political platform. Just think your way through what you're going to throw your money and your time and your effort behind, and do good things to help people. There's 5 minutes left. I'll shut up. Is there any questions I can try to answer or politically dodge around since I'm on the clock right now?
Rick, did you explain the comforting lie versus the painful truth?
People, the phrase on the last slide.
Yeah, that one.
So like examples.
Yeah,
It must be
I just want to know what that means.
okay. It's not us, it's them. That doesn't happen in our community. It happens in that community. It's never here. It's always over there. It's those people, so it doesn't matter. If you roll back and look at some of those maps, especially the methamphetamine one, it's the whole state. And everybody is affected by this somehow. Maybe it's not, you personally or a family member or a friend. It affects all of us in some way, shape, or form. Here's a politically dangerous thing. So there's going to be a special session this year because they have to balance the budget and all that sort of stuff. That's what we do. And so all of this has an impact somewhere, even down to the point of how tax money is divided up. Does the money go, and is it allocated towards substance use disorder treatment versus law enforcement intervention versus healthcare through emergency department versus whatever it happens to be. So people get busy rationalizing stuff because it somehow makes sense to them and it's more palatable. People like to be comfortable. They don't like to look at ugly stuff. And sometimes looking in the mirror is not pleasant. Because, we're Minnesota lice. Nice. Hoofda, lutefisk. Tater tot hot dish. Yeah, lutefisk. About that. Anyway.
Hey, Rick, we've got a question about 2020 data. When is that or how is that available?
2020 is not yet available. Normally, we do Danes runs by April of the following year, which would mean normally we would have 2020 data right now, except COVID. Any questions? As soon as I can get 2020 data extracts, I'm going to update all the slide decks and everything you see. So at some point in the future, I will have all the stuff updated again because I kind of do this annually. The best thing I could tell you is to maybe shoot me an email. Let's see, this is May, in a couple of months. And if I have it, then I'll have the slides updated. I can send you all the stuff then.
Oh, Rick, we can also have you come back sometime. That'd be great.
Okay.
Can I ask
Couple minutes. Go ahead.
I just want to ask a question. It's kind of a touchy one, but just when you were talking about how the babies are not born addicted, they're born with a physical dependence, and just kind of the way that you said, they're not addicted because they didn't have a choice. And I wonder sometimes if that's where the stigma comes in, is that the choice was made, and even just the way that was described kind of made it seem like there was a judgment on the fact that you chose and the baby didn't. And I just wondered how, I've loved this presentation, but I just wonder how you can just describe that a little bit.
Okay. Yeah. The way I mean that is, whoops. Can you still hear me?
Yes.
Okay. My computer just went black there for a minute, so I immediately panicked because technology. What I mean by that is, again, purely from a diagnostic standpoint, if you look in DSM under, say, inhalant as an example, in order to have an inhalant use disorder requires the intent that somebody use, that somebody seek some form of intoxicant or volitionally makes a choice to do it. And so what I mean as a correlate to that is that the baby, the fetus, has no choice in whether or not they're exposed to it. I'm not suggesting that also extrapolate over specifically to mom. What I'm saying is, again, using inhalant as an example, somebody who comes into the emergency room that is under the influence of Freon because they work in HVAC and was in an environment where they inhaled lots of Freon, they're not going to be labeled as an addict or intoxicated because there was not an intentional use as described by the DSM. And so when baby is on board, baby's exposure is passive. It's not volitional. There's not an intent for it. And so consequently, we should not adamantly should not say that babies are addicted because of passive exposure. I don't know if that made sense to you or not.
Yeah, no, I get that. I totally 100% agree with that. I just was, yeah, I was just in the mindset of that's where the stigma kind of comes in, is when you say the choice. But that's,
Mhm.
yeah, it's a hard, I know. I just,
I've got a longer, kind of more eloquent speech that I usually break down and start crying during. When I do some of these kind of presentations too, I just, with our time constriction, I don't get to go into a lot of the details of it.
gotcha.
So
Yeah.
I'm,
And
yeah.
we will invite Rick back maybe, or you can catch him at another conference because he does present often. We're right at one, little after 1, and I want to make sure I'm respectful of people's time. If you haven't already, please put your name in and email into the chat so we can your attendance and you can follow up with an evaluation. We do share all this information with Rick and our presenters every time. So it is good feedback for them, also helpful for us in making plans for future ECHO sessions. Speaking of which, on Tuesday, we have an Indigenous Women Wellness ECHO, and it's going to be with Julie Williams from up on White Earth, and she's going to talk about the MOMS program and how they work with pregnant and parenting moms and families. It's an amazing program. If you don't know about it, you should know about it. And if you haven't received an invitation, email me and I will make sure you get it. You do need to register, but there is no charge for that, of course. And we're also doing a Friday forum tomorrow on trauma sensitive, justice-based yoga program that they're using up in the 6th Judicial District to work with people in treatment court. Interesting program. I can't wait to learn more about it. And I can help you with registration with that one as well. There is a small fee. As always, we appreciate that you're here. Thank you, Rick, for sharing all the information with us. And I'm going to go ahead and say good day. Have a wonderful day. And I hope we'll see you again soon at a future ECHO event.
You betcha there.
Thank you.
Yeah, sure. You want to hang on for a minute while everybody else goes about their daily business?
I will.
Okay. I was just curious to see, with you doing the slides, I think is why this worked, because it cut down on a lot of the bandwidth from my end. So it was able to keep the signal. Did you notice any problems with toggling the slide from your end?
No, it went really well. The only problem is that Zoom has that black bar that lets me come in and out of the Zoom room, and I get it to go away. So I would kind of guess what the important information was based on what you were talking about, and I'd move the bar so people could see, the legend, and they could see the titles. And
I saw the bar.
Well.
I saw the bar move around, and I was getting uptight, thinking it was going to like go, like to a black screen or something.
Oh, I'm sorry. No, that was me trying to let it be well seen by others.
Okay.
Because I couldn't figure out how to get rid of it.
Right. Well, that was a tremendous amount of data dump inside of about 50 minutes. So, cool.
Well, you may get some questions then. We did make sure everybody got the copy of the presentation, so they all have your contact information.
All right. Well, I will